I saw all kinds of wonderful things you guys in here. No, I was just saying I apologize, as usual, woefully underprepared. I've been in a series of other pieces, so I've just been kind of bouncing back in and out of this. But this has been just amazing to hear, and thank you so much for really carrying this important issue forward and for educating all of us on a really wide range of topics. I'll just say a couple pieces and then get out of your all's way. Behavioral health, so behavioral health focus. But when you talk about these issues, I think it's important to recognize that since the 1950s, we've actually closed over 90-95% of state hospital beds from a behavioral health perspective. And there were concerns of abuses in the 60s and 70s, and those concerns were well founded. But what we saw is that it wasn't really deinstitutionalization, which was the goal, the stated goal, but trans-institutionalization. So we had all these individuals, because there wasn't the commensurate increase in outpatient behavioral health services or funding, that went through a prolonged downward drift where they had burned bridges with their family, their friends, until they end up in the lowest common denominator, which would be community emergency rooms, community hospitals, psychiatric hospitals, and of course, jails and prisons. And so that's how, and I know this sort of sets the stage. I think Judy's going to talk later, but the three largest mental health institutions in the country are actually jails in LA, New York, and Chicago. And if you go to any medium to large American city, there's a fair chance that the highest number of folks with behavioral health issues are actually incarcerated there. It doesn't have to be that way by any stretch. RAND, which is the nonprofit out of, I think, Santa Monica, looked at LA County's jail system, and there they found about 61% of their folks with behavioral health issues could be diverted or treated an outpatient system of care. Additional 7% were maybe, and then the remainder they figured had to be remain in jail. But that's when you translate that to numbers in Riverside County, there's a very large number of individuals that we can treat and care for more appropriately. And this is, again, due to things that society did 60, 70 years ago. We're sort of, reaping what we sow and have a chance to hopefully take a stance and move back, as it were. A couple parts that you might hear about, have heard about today, just the way how health issues disproportionately affect folks of different backgrounds. But for behavioral health, people with serious mental illness die on average 15 and 20 years younger than the general population. In Riverside County, it's much worse, for folks who are dying at the average age of 42 years old. And really grateful to the leadership of RUHS and just the fact that we can operate as a system, that we're to help combat that. We're now in all of the RUHS community health centers, or FQHCs, where we have psychiatry, therapy, and substance use disorder services. One other thing I just want to mention about the prison and jail system, there's a book that's called In My Father's House. And apparently in the prison system, 5% of America's families make up 50% of the prison population, 10% make up 2/3. And so when you start talking about targeted intervention and targeted services, that's a lot of what we're trying to look at doing, because we know that when we wrap intensive, aggressive outpatient services around our consumers, around our patients, we know that they do quite well. We know that they stay out of the hospital, they stay out of the jail, and they move away from the condition of being homeless. Last thing I just want to say before I turn it over to the superstars here. I've heard HPI mentioned several times, and I will happily confess that we have tried to steal wholeheartedly all the HPI work done by public health and Dr. Leung and Kim and everybody. And so we're looking to build recovery villages. And so these are places for folks with behavioral health issues. And yes, it focuses on behavioral health and physical health and housing, but also on social determinants of health. So we'll have supermarkets with healthy food access, the green canopy, the tree canopy that was mentioned, green space, education, vocational training, all these things that we are learning from you all mean much more than just what we focus historically in behavioral health. The flip side of that is where we're looking to put these places, and I'm going to get these numbers a little wrong, but we're looking to build the first 2 recovery villages in the city of Coachella and Hemet. And so I think someone mentioned Riverside County's HPI as an overall number, but for Coachella, that HPI score is, I think, 10, 10.8, and Hemet, it's 6 point something. So when you look at just these huge areas of need throughout the county, they certainly exist. And we're hoping to, with the learnings that we've garnered from the health system and public health, tailor our services and our strategies more effectively. And so with that, thank you. I believe Maria Martha Moreno is going to get to go next and get to talk about something super cool. So I will turn it over to her. Thank you.
Thank you, Dr. Chang. Thank you, everybody. Thank you for the opportunity to share with you what the Help a Hand Riverside program within behavioral health has been doing. We are part of the statewide collaborative of 12 counties and 2 cities. And within that Help a Hand program, one of the innovations is the TakeMyHand live peer chat. This particular slide shows you the great team that has been working very hard since the pandemic started at the direction of Dr. Chang. We did a rapid implementation in March of 2020. And as you can tell, this particular team is a little different from other projects. And the main reason for that is because this collaboration integrates lived experiences. So aside from our application developer, administrative staff, we have a team of peers. And I have with me today Melissa Vasquez, who is going to co-present with me. Also, another of our new team members is our bot hub. You were able to see it there. So today, Maria Marta Moreno, the Help a Hand program manager, and we have Melissa Vasquez, our senior peer support specialist. So we can go to the next slide and basically just tell you that we do have multiple innovations going on and in progress and in development for the past 3 years. We only have 2 more years. So that's why we are working very hard to ensure that we do what we said that we were going to do at the state level. So we need to integrate new technologies, and we do need to integrate lived experiences to improve the well-being of our community. So we can go to the next slide. TakeMyHand live peer chat is one of those innovations. And I'm going to pass it on to our senior peer support specialist, Melissa, so she can tell you a little more about what TakeMyHand live peer chat is.
Thank you, Martha. Thank you for having me here today. I just wanted to let you guys know what TakeMyHand is, and also what the live peer chat is. So TakeMyHand is a website that offers live peer support in a texting format. It's free and you can remain anonymous. Riverside University Health System Behavioral Health sees the importance of hiring people with lived experience and that also have recovery in mental health and substance use. We are able to provide a mutual, non-judgmental, safe space for the community to share their truth. We can support them with emotional wellness, coping skills, and resources. We're able to help our visitors build resiliency when their life becomes difficult. We're able to explore the recovery processes for those who may struggle with emotional difficulties and/or substance use challenges. Next slide, please. So this is one of our social media ads that we have on Facebook as well as Instagram. And we basically just kind of relate the message that I just conveyed, which is, a lot of times we're taught to be strong and pick ourselves up, do it all on our own, shove down what we're really feeling. Sometimes we don't even tell people closest to us that what we are going through because we don't want to feel like we're a burden. We know how important it is to feel heard, validated, and understood. Our peer support specialists are here to uplift you and help you find hope again. Your journey to wellness starts here. If you could go to the next slide.
1 minute.
Ooh. All right, so then this is just another example of that. And then can you go to the next slide? All right, so we also won the 2020 CSAC Challenge Award. And that was a huge honor for us. And I just wanted to share 3 quotes from people who have visited our website. They felt lifted, their spirits, lifted my spirits, gained some confidence. He's nice and he understands how I feel, easy to talk to, and really pays attention to every expression like it really shows, and she cares. I'll send it over to Martha now. Thank you.
Next slide. Okay, so as an effort to reach our community, we did implemented kiosk technology in which this live peer chat is available. We found the need to make sure that our desert region, Mid-County, do have access to this kiosk technology that has the access to the live peer chat, TakeMyHand, and to other educational resources. So we can go to the next one. Basically, that's how our landing page looks like. So we can go to the next one. We do have a kiosk map locator that is available so the community members can see where the closest kiosk is. So they can locate a kiosk and be able to access those resources. Next slide. We did a massive campaign on billboards in the desert, Mid-County and Riverside in English and Spanish. Next. Bus wraps in the desert, English and Spanish. Next. Bus shelters. That's important because most of our clients are actually taking the bus. We did it in English and Spanish, Blythe, Thermal, Coachella, and Desert Hot Springs. Next. We work very hard with our cultural competency liaisons to ensure that we create infographics that connect more or that people can relate to. So we are addressing the needs of our diverse community. So next one. We can play a radio and maybe we can finalize with that. You will have a copy of the presentation as well so you can learn more about it. Oh, it seems like we couldn't play it. Okay, it's fine. Can you play it? No.
Maria, it's not allowing me to play.
Oh, okay. Okay, so maybe we can just make that presentation available to everybody. So next slide. So if you have or know of someone who needs real-time support, we are just keystrokes away, you know? You can access it and access us via telephone, your computer, or go to a kiosk in the lobby of one of our clinics. We have one kiosk in the medical center as well. And you can start feeling better by accessing our peer support services. We have other innovations coming up and you can learn all about it in the copy of this presentation. Thank you so much for having us.
Thank you, Maria, Melissa. Up next, we have Judy Nightingale. She is a Director of Population Health with RUHS Center and Clinics.
Okay, so hi, everybody. Put your seatbelts on because I'm going to try and zoom through this presentation. And thank you to Dr. Chang for setting the perfect platform for me to talk about this population. If you can go to the next slide, please. So this is the focus, the goals, and the method by which we operated our whole person care pilot that is a justice involved transition effort. Next slide, please. We hired 8 RNs in all probation and parole sites in the county. We added 12 housing outreach specialists through behavioral health and 8 case managers that sat in our CHCs. Next slide, please. And then we screened in probation for health insurance, mental health, medical health, substance abuse, homelessness, and social services, including Dentacal and Medical. Next slide, please. As you all know, there are many obstacles at release. I highlighted a few key words here because I had a feeling, being late in the day, I might need to zoom through this and catch up. So I think most everyone in this group is familiar with the obstacles that people face as they exit incarceration. Next slide, please. We know health outcomes of people that have been incarcerated are much worse. There's a higher risk of chronic conditions. There's a higher risk of communicable diseases such as hepatitis and HIV and other STDs. Next slide, please. We also know that anyone who's previously been incarcerated has a higher mortality rate and a lower lifespan expected. During the first 2 weeks after release, the risk of death is 12.7 times higher than the general population. And most of the leading causes of death in this population are from drug overdoses, cardiovascular disease, or homicide. This was an interesting data point. Each additional year in prison produces a 15.6% increase in the odds of death for parolees and a 2-year decline in overall life expectancy for each year they served in prison. Next slide, please. We know that when people come out of incarceration, if their needs are not met, they do not get connected and they do go back into incarceration. So a nationally representative Bureau of Justice Statistics found the following statistics. This was in 2005. So 67.8% of clients were rearrested within 3 years and 76.6% were rearrested within 5 years. More than 4 in 10 offenders nationwide go back to state prison within 3 years of their release date. Next slide, please. We know that there is a disproportionate amount of people in incarceration with mental health and substance use issues, and Dr. Chang also mentioned this earlier. We know that about 2/3 of people that are incarcerated in the US meet the criteria for at least one mental illness. We know the rate of serious mental illness is 4 to 6 times higher in jails than it is in the general population. We know most incarcerated individuals also have a very high burden of substance use disorders. Some would posit that that is in response to their mental health and their own attempt at self-medicating. We also know that a history of substance use has consistently been reported as a predictor of recidivism. And also we know that the co-occurrence of mental illness and substance use significantly increase the risk of reincarceration or incarceration. Next slide, please. We also know that many of the people who are homeless have been in incarceration, and my team reports that about 80% of our probation population, we've screened 15,000 people, report having been underhoused at exit from incarceration. We know that 15% of the jail population were homeless in the year prior to their arrest, which is a rate 7 to 11 times higher than the general population. Next slide, please.
1 minute.
Okay. We also did some statistical analysis on more than 6,100 screened and referred patients, and we found that the co-occurring mental health and substance use was more likely to be incarcerated, and people with mental health diagnosis had twice the odds of reincarceration, and if they had both substance use and mental health, 3 times the risk. Next slide. I think I'm almost done. So this was, I'm just going to not read this, but tell you that the wonderful thing we found as a result of our analysis on our 6,000 plus probationers, when the screeners found a need to refer those clients into behavioral health for substance or behavioral health care, and if those clients showed up for just one appointment, we reduced reincarceration in the group that showed up for one appointment in behavioral health and 50% for those that showed up for one appointment for substance use. And if you can just go to the next slide, I think it's my last one. This is how many screenings we've offered. We have an acceptance rate of 96%. Next slide. I think the next one's my final one. This is just the number of referrals per clinic we made for a total of 21,000 referrals made for 15,000 people. And the next slide has my email if anyone wants to ask me any questions. Thank you. Oh, that's a success story. You can read that on your own. Thank you.
So next we have Dr. Mosem Bajwa, who's one of our family medicine residency faculty, and also is one of our champions for community medicine. Thank you, Dr. Bajwa.
Thank you, Dr. Leon. Can you hear me okay? Alrighty, if you go to the next slide, please. So my talk today is discussing our Food as Medicine program that we started at RUHS UCR Family Medicine Residency Program. Can we advance the next slide, please? Thank you. So if we just back up just one slide, I think my computer is maybe going a little bit slower than what I'm seeing here, but essentially the idea is there's two issues that we're addressing in this program. One is the rates of childhood obesity that have been skyrocketing in Moreno Valley. We already do some high school outreach and education with our program called HELP, which was started by Dr. Sang back in 2012, I believe it was. And this is a program where we take our residents once a month out to do advocacy and education around reducing rates of childhood obesity for adolescents and children in Moreno Valley School District. But we decided that we were missing the direct action in terms of mitigating the harms from food deserts and how that was contributing to higher rates of obesity in Moreno Valley. So the idea was to come up with a screening program around food insecurity and then implementing a food RX for shelf-stable foods first, and then potentially partnering with local farmers to do the same thing with fresh produce. Next slide. Are the slides advancing on your end?
Dr. Bajwa, it is advancing on our end. Are you not able to see one with a map?
Yes. Okay. Yeah. So now the map is just coming up right now. So this is just highlighting the areas that have the highest obesity rates. So in the tan and the red with the stripes. So the striped areas being the highest levels of obesity, and then also the red areas being marked as those that are a food desert. And as you can see, most of the areas that are 11 CHC service fall in one of these areas that not only have high obesity rates, but also classify as a food desert. Next slide, please. And I apologize that the slide transition seemed to be lagging a bit on my end from what you guys can see. I think just my internet connection is a little bit slower, but bear with me just a moment. So our plan is to identify patients from our clinic who have chronic medical conditions using the hunger vital signs 2-item screening. Next slide. And this constitutes 2 questions that basically ask whether patients in the last 12 months have experienced food insecurity, or whether in the last 4 weeks they've had any issues getting the nutrition that they need. Next slide, please.
1 minute.
So how we did this was basically we partnered with Feeding America Riverside to distribute food boxes into our clinic space. We started with a small amount, about 50 or so, but increased that up to 75 boxes per month. And the reason we did that is because in our first screening, we did a pilot screening from January to April in 2021, and we reached as high as 40% of the patients that we screened with positive for food insecurity over that 3-month period, which was much higher than we'd initially suspected. Although looking at the numbers from Dr. Baum's presentation, that kind of runs similar to what they saw, and their numbers around 39%. And so the food boxes themselves aren't necessarily a solution to food deserts and high rates of obesity, but they fill a sort of gap that we could partner with community agencies and resources, such as Feeding America, to directly provide food relief to our patients. There's still a lot of work that needs to be done from a structural standpoint to impact the food deserts, and those are more on the policy side of things. But it's important that at the front-facing CHC level that we at least do what we can to mitigate the harms from the food deserts, and that's where the food boxes come in. And since we implemented the program in November, we've distributed a little over 550 or 590 food boxes. And so we have a few plans now to integrate better into our EHR, because everything we've been doing has been on paper. And then also to evaluate how the implementation of the food boxes has affected the health metrics for those patients. And then we're also planning to expand to other CHCs starting next in the Rubidoux Clinic in July of this year. So thank you guys for taking the time, and also for letting me be part of the excellent conversations that have been going on today to address health disparities and inequities in our community.
Next, we have Dr. Pasqua from the Department of Anesthesiology.
Hi, thank you for having us on this panel. I'll actually be giving this presentation with Mullen, who has been our coordinator here for many years. So the idea came probably in 2018 because Riverside County has insufficient physicians for our patient population, especially physicians from specialties and underrepresented minorities. Research has shown that patients who are cared for by physicians of their own background have improved follow-up and improved care, improved long-term outcomes. So our goal was to increase the amount of local high school students that were interested in medicine that would come into caregiving. And so we started a program that was specifically targeted towards high school students to increase interest in medicine.
Okay, so I'm just going to give a short background to our program. So it began in 2018 with one of our third-year residents, Dr. Patel, who had an idea to start a program to provide opportunities to underrepresented youth who face unique challenges in entering the world of medicine. The program was called Advancing Youth in Medical Education, or we also called it AIM. With the goal of immersing students into clinical practice, educating them on different paths of becoming successful in medicine, engaging them in matters involved with diversity and women in medicine, exposing them to the challenges faced with medicine today, with the hope of encouraging them to become future leaders in medicine. As Dr. Patel graduated, Dr. Favis took over the program as a third-year medical resident in 2019, and she renamed our program to Medigal Goal, goal standing for Guidance, Opportunity, Achievements, and Leadership. And currently the program is continued and led by one of our incoming chief residents, Dr. Kong. Both AIM and Medigal partnered with TRIO to serve the students that are involved in that program. Last year, we had a group of 35 students who participated in the program. We also provided mentorship to the students of the program, and many of the RUHS residents participated in this mentorship.
So our goal was to partner these high school students with long-term mentorships from current residents across specialties of surgery, internal medicine. And we've been quite honored to actually have one of these students from Moreno Valley High School who got into Harvard last year and is actually here this summer doing research with us and giving back to her community already. Next slide, please. So we had multiple different projects that we've involved these students in, including this year we had a large RUHS Airway Day workshop. We had over 100 participants from across Riverside County, including respiratory therapists, nurse practitioners, paramedic students, medical students, and fellows. And so through this, we actually were able to mentor many students who came back and asked us for opportunities to do research and opportunities for future collaborative efforts with us. Next slide, please.
1 minute.
And so through this collaboration, we were able to work with surgery. We taught them not only how to improve the management of the difficult airways, but also we've been able to now increase their exposure to medicine, to improve their CVs, to get them into mentorships and to letters of recommendation. Next slide.
Okay, so I think our latest version isn't here, but let me just say quickly that we had a slide about if you are interested in participating and oh, here it is, and learning more and getting involved, please visit the RUHS Anesthesia Residency website. We have a video that was created by the TRIO students about their experience with this program. If you click again there on the slide, yeah, there go to our website, look for click again, look for the Medigal is right there at the bottom, and then click again. Then we have you'll find also there's an interest form that you can click on and submit, and you'll be contacted about how you can participate and join. Thank you.
Thank you.
Thank you so much, Dr. Pasqua and Malin. Next up, we have Sabrine White, who is the Program Director for Her Care, High Risk OB and the Women's Health Center, and one of our DEI Task Force members.
Hi, thank you. Good afternoon. My goal is to introduce you briefly to the Equity and Diversity Advocacy Taskforce that we have created here at RUHS. Next slide. So where it all began, on Tuesday, August 4th, 2020, Riverside County Board of Supervisors declared that racism is a public health crisis. So our champions on this task force is Dr. Kumar and Dr. Leung. Our task force members are across all the arms of RUHS. So we have Marcela Carpenter with Public Health, Jimmy Hernandez with RUHS Medical Center, Brandon Jacobs from Behavioral Health, Kalisha Mays from RUHS Quality, Gigi from RUHS Nursing and Quality, Judy from RUH Population Health, and Kirsten Odell, RUHS Quality, Sarah Rodriguez from RUHS Marketing, Lynetta Skoritz from Internal Medicine, Erin Sullivan from RUHS Medical Center, and myself, I'm with Her Care and Women's Clinic. So what is the vision? So the goals of our task force is to educate, engage, measure, share, partner, and improve. And the mission is to reduce disparities within RUHS through education, engagement, data-driven improvement, and partnerships to promote diversity, equity, and inclusion. Next slide. So what have we done? So what we've done is we actually started in November of 2020, and we have established weekly meetings, the RUHS Equity and Diversity Advocacy Task Force. We had a DEI workshop last year, and then of course this one this year. We also started the Innovation Magazine, where we did do an article on DEI. We did our grand rounds October 20 of 2021, and we are also getting ready to. Oh, am I? Okay. Thank you, Dr. Johnson. So what we've done this year, January 2020, is that RUHS joined the California Healthcare Safety Net Institute, or SNI. We are part of the Racial Equity Community of Practice program, which is an 18-month learning collaborative that supports public healthcare systems' ability to advance racial equity in their organizations. Along with its partner, the National Equity Project, or NEP, which is an Oakland-based leadership and systems change organization with deep expertise in advancing equity. We're super excited to share that our cohort includes nearly 70 leaders across 12 public healthcare systems. Next slide.
1 minute.
So what does the future hold? So the goal is obviously to educate as many people as we can. So we are going to start implementing implicit bias training institution-wide for all of our RUHS and the different arms. We are working on a DEI survey, inventory of quality, DEI measure, disparity reduction. We have 5 process improvement measures. We are going to continue to put in articles in the Innovation Magazine. We're going to continue our annual DEI workshops, and we are working on creating an annual newsletter. Next slide. Thank you. And next up, we have Dr. Lenora Clark. She is our OBGYN faculty with Women's Health Center.
Hello, thank you for having me. We'll be talking about what our department is doing for disparity reduction initiatives. So the first part of addressing any problem is recognizing that there is a problem. And here in our department, we definitely recognize that. Some notable statistics, which are unfortunately saddening, but factual. Maternal mortality is 3 to 4 times higher for Black patients as compared to white patients. And that's even when you control for socioeconomic status. Preterm birth rate is 18.4% in Black women as compared to 11.7% in white women. And as far as access, there's definitely access disparities in OBGYN. For example, 49%, half of US counties lack a single OBGYN, and we're definitely working hard to address that. Next slide, please. So one program that we have, which has been quite amazing, is the Her Care program. It's the High Risk Care Access and Resource Program. It was established in July 2020. It's a 4-year, first 5 grant-funded program. It's dedicated to allowing access to MFM services, which is high-risk OB, including ultrasounds, telehealth consults at local community health centers throughout the Riverside County. And we're affiliated with clinics from Corona all the way to Indio. So some of these areas really don't have much access. So this is making a big change. We are working on establishing a research endowment. We're going to be focusing on not only pregnancy, but other health indicators beyond pregnancy. And we're working on establishing a perinatal access call center with real-time access to urgent medical questions. Next slide, please. As far as research efforts goes, again, we're just constantly working on how we can improve ourselves. We have recently applied to a large grant, which is the Inland Empire Maternal Health Equity Research Network. It's a grant that would look at the effects of screening and referrals for depression, anxiety, but also social determinants of health on perinatal outcomes. And we hypothesize, which I think is reasonable, that screening and treatment of mental health disorders and addressing these social determinants of health will decrease adverse perinatal outcomes. So this would increase our access to behavioral health services and social work services as well for our pregnant patients. We also are about to participate in sitting on the committee for the California Pregnancy Associated Maternal Review Committee. And this is actually really critical. We talked about the maternal mortality rates, and this committee conducts a comprehensive review of every maternal death in California from all causes, Southern California, let me correct myself, from all causes. It includes not only review of the medicine, things that we can do better as far as the healthcare aspect, but also looking through a health equity lens to better understand pregnancy-related mortality, and also to provide recommendations to the community to see what we can do better. So we are participating on efforts not only on campus, but on a local and national level as well, and we're hoping that we can continue to make a difference for maternal health. Thank you for having me.
Thank you so much, Dr. Clark. Next up, we have Carrie Stuland from our Language and Cultural Services Department. He's the manager there, and he's going to talk a little bit about language disparities in healthcare.
Thank you very much. Next slide, please. Next slide, please. So what is LEP? Patients that we have in our hospital organization have LEP, have limited English proficiencies, and there are quite a few definitions of LEP. Here are a couple of the definitions that we have here. But here within language and cultural services, we like the definition that's on the bottom, which is the limited ability or inability of individual to speak, read, write, or understand the English language at a capacity that would permit the individual to effectively participate in his or her healthcare. Why do I talk about LEPs? I think it's important to identify LEPs as a substantial population, a percentage of our population, knowing that as healthcare providers, we're definitely going to run into LEP patients. Next slide, please. Here in language and cultural services, the abundance of LEPs allows us to, we have in-person encounters. We manage a team of dedicated interpreters who perform communication services for our in-person encounters. And as you can see on the blue bar graph on the left, our in-person encounters are getting higher and improving every year. We've gone from about 26,000 in-person encounters, almost up to 30,000 in-person encounters within the last 3 fiscal years. Our remote interpreting services on the right-hand side, you can see that they were drastically affected by COVID. They have gone up considerably over the last 3 fiscal years. And now that COVID is somewhat abated, they are flattening out a little bit, but we expect both of these categories to continue to rise in the near future. Next slide, please. I present to you a cultural sensitivity checklist. It facilitates cultural awareness and sensitivity as healthcare providers. As healthcare providers, I believe that before we treat LEP patients, we need to go ahead and ask ourselves if we have any biases or prejudices, or examine your own biases and basically leave them at the door so that we can go ahead and provide culturally based healthcare within our system. Next slide, please. So the benefits of being a culturally competent healthcare organization, I believe in this form, has been presented recently. So there's also obviously social benefits, and there's healthcare benefits and the organizational benefits. As an organizational benefits, we believe that incorporating different perspectives and ideas within the organization will allow our organization to be more dynamic and move towards cultural competency within the organization, just like we strive for cultural competency as well. Our next slide. Thank you.
1 minute.
Thank you. What are we doing to reduce language disparity? Here within language and cultural services, we are providing quality in-service, in-person interpretation and training, which bridges the communication gap between medical providers and staff and patients. We're investing greatly into the latest technology, which allows our interpretation services to be virtual and mobile. We're providing training and technical assistance to our inbound or our recent hires through Moodles. We continue to provide presentations on our incoming resident class and our health coaches on the best use of an interpreter and how to maximize the use of an interpreter. Next slide, please. We feel that we can still do better. We currently, RUHS is a diverse workforce. We believe that we should continue to onboard staff that are culturally competent and have experience in cultural competency, as well as a skill set. We also believe that there's education to train our current workforce in the benefits of cultural competency and the language disparities. And we also believe that has to be a change in culture. A few years ago, it wasn't the culture for physicians to walk into the room with their washing their hands. Now we think that the cultural change or the cultural onlook towards providing healthcare for LEPs needs to be on par with any other patients that we expect healthcare for all LEP patients just as we would any other patient. Next slide, please.
And we're at time.
Okay. Just in closing, I think that language and cultural services can have teamwork. We can include our interpreters in a team approach to healthcare. We can use our interpreters as health navigators to guide patients, use our interpreters as cultural brokers within the healthcare workflow, and use our interpreters as safety checkers to and make sure dangerous miscommunication doesn't happen. Next slide. Thank you very much for your time, and I appreciate that's my contact information, and feel free to reach out to me anytime. Thank you very much.
Thank you, Carrie. So up next, we have Kirsten Odell. She's from Nursing and Quality.
Good afternoon, everyone. Today, I just want to share a little bit about how health equity is integrated into our quality improvement programs here at RUHS. Next slide. So RUHS has been participating in California's Pay for Performance programs for public healthcare systems for over a decade. And we've been seeing an increase in focus on health equity in our quality measures over that past decade. Starting in about 2015, we had the PRIME program, which is the Public Hospital Redesign and Incentives in Medical. And that's kind of what got the ball rolling as far as data-driven health disparity reduction efforts, because we're really focused on all the entities reporting their real race, ethnicity, and language data, as well as sexual orientation, gender identity, or SOGI data. And from there, we use that data to stratify a metric of our choosing, identify a disparity population, and then create a disparity reduction plan. And so PRIME has transitioned into QIP, which is the Quality Incentive Pool. And starting in 2021, QIP is requiring all entities to report on one common quality measure using the same race ethnicity stratification to basically have one standard improving health equity measure that's required to report on. And in addition, they're also asking for us to stratify 5 quality measures by race ethnicity to for basically informational purposes to help inform future expansion of the health equity in quality. Next slide. And so basically this year what we're doing is we're taking the diabetes A1C poor control measure, and everyone is required to stratify by Hispanic Latinx population and Black African American population. And our goal really is for each of the subpopulations to achieve the metric target along with the parent population. Next slide. This is the stratification table that the state provided to us, and this is basically how we break down the race ethnicity for each of the patients in the quality measure. We can report the numerator and denominator for everybody who would identify as a particular race or ethnicity. Next slide. And then we have done trending for how our population is doing over the year. And so for this metric, lower performance is better. So the top dotted line actually represents the minimum performance 25th percentile, and the bottom dotted line represents the high performance or 90th percentile. And as of December 31st for this year, not only did we achieve the minimum benchmark, our total population and our Black African American population hit the 90th percentile for diabetes control, and our Hispanic population was only 0.1% away from the 90th percentile. And what's even better to see is that everything is trending in a synchronized way, which really to us reflects health equity. So we're happy to see that. Next slide. I'm just going to jump down a little bit and just generalize and say that we're also now working with IHP in their Global Quality P4P program for the first time in 2022 to also address health disparities. And so we have a work plan in place. Next slide. They've also been identifying their disparity populations. And so for A1C control, they've identified Hispanics and American Indian and Alaska Native as our highest disparities for diabetes control. Next slide.
1 minute.
Thank you. And so the last thing I just want to share is that, we also received a grant from Kaiser to work on blood pressure control over the past couple of years. It was transforming cardiovascular care in our communities. And so we set about improving workflows and, different things we could do to improve hypertension, blood pressure control for our hypertensive patients. And then the pandemic hit. And so then we were forced to really shift course. And what happened was, as patients were sheltering in place and we were really shifting to telehealth. We realized that in order to measure outcomes, patients really had to have home blood pressure test kits in order for us to monitor these outcomes. And that's where we identified a financial disparity, because not all of our patients had a health plan that would cover a home blood pressure test kit. And some of those patients, I think we were looking at maybe nearly 40%, had to pay out of pocket. So what we ended up doing was using our grant funds to purchase blood pressure test kits, distribute them to all of our community healthcare centers, and then we created a work plan for how do we distribute these to our patients, educate them, and do the monitoring. And as a result, we received a Quality Leader Award honorable mention from the California Safety Net Institute for our work in controlling blood pressure in the midst of a pandemic. And this article is also published in our Innovations magazine. So if you would like to read it, is it okay, Dr. Kumar or Dr. Liang, if we can have them reach out to you for a link to that magazine?
Yes, please.
Absolutely.
And that's my presentation. Thank you.
Thank you, Kirsten. Wow, we made it to the end of 3 hours. What a remarkable and incredibly inspiring 3 hours. I have the hugest smile on my face. We hope that you have learned from each other, made new connections. Let's continue to partner together to strengthen the impact in our community. I want to thank all of the presenters. A huge, huge thank you for coming out, for putting together such great presentations and sharing your work with us. A big thank you to the RUHS leadership team for supporting this activity, and to the RUHS Medical Center CME committee for supporting and providing educational credits for this activity. Please remember to fill out your CME forms if you'd like it. Also, we are actually very much on time. We packed a lot, and thank you to Dr. Leung and Dr. Kumar for doing the behind the scenes work. We hope to see you in the implicit bias training up next. But before we go, I want to just say a big, huge shout out to Dr. Kumar and Dr. Leon. They have done an incredible amount of work in addition to our task force, and I want to give them the chance to have a few final words. Before I do that, I want to welcome any feedback from you folks to our task force, so how we can make this better and to continue this conversation. Drs. Kumar and Dr. Leon.
So Dr. Skorec, thank you very much. And this has been a labor of love for us. And, it took a village. And, we're very thankful to the task force, the Equity and Diversity Advocacy Task Force, and all the team members and the presenters and the facilitators. And also our leadership, there was no hesitation. Everyone was more than willing to join in and say a few words. So thank you all, and we look to see you at the implicit bias training as well.
And I just wanted to take a moment to thank everybody for carving out such a large portion of your Thursday afternoon to be with us. Thank you again for the fantastic presentations, and a big thank you to Dr. Skorec for taking us through the whole afternoon as our MC. Thank you.